This slide is basically showing the mechanism of development of acne. So acne is basically a disease of the follicular canal of the sebaceous follicles. So what happens is there is excessive thickening or inflammation in that area of the follicular canal, and then microcomedones in the form of open or closed comedones appear. When there is excessive secretion or sebum, then there is also invasion by bacteria, and the culprit bacteria, which is basically known to be involved in this case, is Cutibacterium. So when all of these things are put together, then comedones develop, and once the comedones develop, they invite neutrophils and chemotactic factors, and these neutrophils are going to release granules and cause all kinds of inflammation, and that's how we see the papules and the nodules and the scarring associated with acne. So this slide is basically just showing different characteristics of acne. So as we know, the acne is basically a condition where there is pilosebaceous unit involvement. So there is hair follicles and the oil glands involved. Therefore, there is multiple mechanisms involved. There's a variety of different lesions that develop on the face, the different parts of the skin, and people call these pimples and zits and all kinds of different things. Then people can also develop papules and comedones, and sometimes we use the terms blackheads and whiteheads, and there is scarring, and acne can happen in any age group, but most commonly it happens in teenagers. And people may say all kinds of different things, but acne is basically multifactorial. So there is multiple predisposing factors, not just one. So there is genetic predisposition. If that is there, people are going to be at risk for developing acne. Then there is hormones, especially androgenic hormones are going to predispose us, which is basically your testosterones, DHEA, and things like that. Then there is environmental factors. So certain environmental situations will put us at risk. Then there is dietary factors, for example, sugars and meat-based products or proteins. Then there is medications that can increase our risk of developing acne. There is cosmetics, which is basically irritation from external sources. And finally, there is immune system dysregulation. So all kinds of different things put together will cause acne. Sometimes people have a few of them, sometimes they have all of them, sometimes they just have a couple of them. But whatever the case, they have at least a few. So to minimize the risk of acne, we can look at all of these targetable areas. So grading of acne is done based upon the lesions. So if we see a lot of them, so basically this slide is showing different degrees of lesions. So starting from mild acne, where there is less than 20 comedones and less than 15 inflammatory lesions, and total less than 30, we call it mild, and then we can progressively increase the severity. For example, we can call it moderate when there is 20 to 100 comedones. We can call it severe when it's more than 5 pseudocysts, and there is scarring, there's more than 100 comedones and all kinds of different things. So based upon how many of these there are, we can call it mild, moderate, or severe. To be fair, to be honest, nobody sits down and counts all the comedones. So just by looking at somebody, you can say this is mild, moderate, or severe. And based upon acne grading, we can do the treatment. So the treatment is going to be mild, treatment for mild acne, moderate acne, and severe acne. And again, nobody's going to stay in the same stage all the time. So they are going to, of course, move from one stage to another, and accordingly we can change the treatment. So for mild situations, we can do topical retinoids, benzoyl peroxide, and things like that to exfoliate the skin. For moderate acne, we can continue the treatment previously mentioned, plus we can add oral antibiotics and topical clindamycin or things like that. For severe acne, we can do oral retinoids, for example, Accutane or something like that, but it is highly toxic, so we need to make sure that we watch for the side effects. On the top sections of the slide, I have the images from UpToDate for acne treatment, and these are just more in detail, more explained. We don't need to necessarily memorize those. As long as we remember the general principles of treating mild, moderate, and severe acne, that should be good enough. And finally, we can also use biologic agents these days. We can use contraceptive pills in female patients, and we can also use spironolactone or anti-androgenic medications to reduce the severity of the acne. Rosacea is a condition where there is a central facial redness and flushing. So there's a lot of redness and there is a lot of flushing. There's papules and pustules. There is disfigurement of the contours. One such condition is called rhinophyma, where there is a swelling of the nose, and that can be quite debilitating, and we call it rhinophyma. Then there is ocular involvement in some patients, not all. Pathogenesis of or pathogenetic factors that lead to rosacea are going to be, you can remember this mnemonic give move, so it's going to be genetic, immune system dysregulation, and then vascular hypersensitivity or hyperreactivity. Then there is microorganisms, for example, Desmodex, which is a mite. Therefore, we can use the scabies treatment, which is ivermectin, for this condition. And then there can be other microorganisms, for example, bacteria. And then finally, there is ultraviolet radiation. So all these things, all these 5 things put together can lead to rosacea. And sometimes people have a combination of some of these factors. So for rosacea treatment, you can remember the mnemonic BALE. So with B we remember brimonidine. Brimonidine is a compound that is used topically to reduce the flushing associated or the redness associated with rosacea. It's very effective, and it causes a lot of patient satisfaction because they can get rid of the flushing, which is quite uncomfortable, and the redness. Then there is azelaic acid, which can be used to help with the skin lesions. Then there are antibiotics, which can be used also, the topical and the systemic antibiotics, because there is a thought that there are microorganisms involved. And ivermectin, which is an anti-scabies or anti-mite treatment, can also be used to resolve the symptoms. Finally, laser treatment can be done to reduce the symptoms, especially if there is disfigurement, for example, rhinophyma. Hidradenitis suppurativa is a chronic follicular occlusive disease which results in severe lesions and recurrent inflamed nodules, comedones, abscesses, and rope-like scars and sinus tracts in the intervaginous areas. So this is a mouthful, and you can think of it in the form of very, very severe form of acne, although technically it's not necessarily acne. People who have hidradenitis suppurativa start out with acne and may feel that they have just a very bad form of acne, but essentially these patients have very distinct features. So they have rope-like structures, lesions, they have scars, they have involvement of the intervaginous areas, they have a lot of nodules, a lot of papules, comedones, and abscesses, and oftentimes these need to be treated very, very meticulously. Treatment of hidradenitis suppurativa basically involves antibiotics. Most of the time you need to use oral antibiotics. There is oral Dapsone for help with symptoms and relief of the symptoms. The oral retinoids, for example, Accutane, can be used. Anti-androgens can be used because those predisposed to this condition. And then lastly, nowadays we can use biologic agents, for example, infliximab and the adalimumab. And the brand names for these are basically, I believe, Remicade and Humira, which can be used. And these are new hopes for these patients because there's a lot of suffering associated with this condition. So next, quickly, we will go over the additional differential diagnosis for papules. We already covered acne, which was the biggest differential diagnosis, along with hidradenitis suppurativa and rosacea. But now we'll go over the real quick conditions, which is basically warts. So warts occur as a result of HPV infection, and they can show like papules, and they can become very big also. So we use topical treatment or freezing. Then there is milia, which is basically in newborn patients or infants who have like small papules on the nose or around the face, and that is basically just milia, nothing to worry about. These are keratin-filled spots, and they will just fall off on their own with time. Then there can be drug eruption, which can show with papules. And of course, we know drug eruptions can result in erythemas, macules, papules, and all kinds of other things too. The next on the mind map is plaque. So plaque is basically, these plaques are basically elevated lesions that are more than 1 centimeter in diameter. Plaques may become confluent, and they can become larger also. As you can see on the mind map, plaques have multiple differential diagnoses associated with them. So we'll go through all of them. So plaques are seen usually in psoriasis. That is the most common condition associated with plaques. But then there is Lichen Planus, and there are distinct features associated with it. And then there is Psoriasis Rosacea. So psoriasis is a chronic inflammatory skin condition. It is an autoimmune disorder where there is multiple clinical manifestations. Chronic plaque psoriasis, or which is one subtype of psoriasis, shows in the form of well-demarcated erythematous-based plaques which are raised, and then there is overlying scaliness. And as you can see in the images, they are distributed in different parts of the body. Most of the time they are going to be on the extensor surfaces, and you can see they are on the knee, on the arm. They can be present on the trunk, and they can also be present on the nails. About 0.5 to 11.4% population has psoriasis, so there is quite a big range. So depending upon what demographics or what part of the world you are looking at, there may be different prevalence, and then they can occur in all kinds of different age categories. About 5 to 30% of patients with psoriasis will develop psoriatic arthritis. So that is important to remember, because a lot of these patients who have psoriasis are going to be at risk for developing arthritis. So if they do start to develop it, we need to watch for it and ask for those specific questions and treat them accordingly, not just treat the skin lesion, treat the whole person. Lastly, there is a genetic predisposition. So there is HLA allele subtypes that are associated with plaque. So the PSORI, that is a gene at chromosome 6p21, which is going to be highly linked to development of psoriasis. So psoriasis subtypes are going to be chronic plaque psoriasis, which is basically just chronic plaques. So they are going to be plaques present in the extensor surfaces or in the scalp area. They can be in the elbows and knees. Then there is guttate psoriasis, which is going to be basically in the form of coins, and that is going to be spread all over the body. It may be on the trunk. Then there is inverse or flexural psoriasis. So this is one subtype which is not necessarily on the extensor surfaces. It's a very small subtype. Very few people have it, and it is going to be on the flexor surfaces, usually in the intertriginous areas, for example, in the skin folds. Then lastly, there is nail psoriasis, and nail psoriasis is going to be on the nails, of course. And the important thing to remember is that these people are going to be particularly at risk for developing psoriatic arthritis. So classic signs associated with psoriasis are going to be Koebner phenomena, which is basically development of skin disease on the sites where trauma is received. So Koebner phenomena is just a general phenomenon, which means that whenever there is trauma to the skin, if the patient has an underlying skin condition, will develop that particular lesion on that area where trauma is received. So for example, if I have psoriasis, I bump my hand or my skin somewhere or do something where there is trauma, then a psoriasis lesion is going to just show up there. So that is basically Koebner phenomena. It is seen in psoriasis, but is also seen in other skin conditions. Then there is another classic sign that is called auspice sign, which basically means there is going to be pinpoint bleeding whenever you remove the lesion. So in psoriasis, whenever you classic sign whenever you remove the lesion. So in psoriasis, whenever sometimes you remove the skin lesion for whatever reason, or patient themselves remove the lesion, there's going to be pinpoint bleeding, and they may become concerned about it, worried about it, but you can explain to them that this is basically auspice sign, and that is a classic sign. So psoriasis treatment depends on the degree of psoriasis. So psoriasis can be mild, moderate, and severe. So if it's very mild, we can do topical and systemic corticosteroids. We can also use over-the-counter emollients, and we can do vitamin D treatment because that helps modify the disease process. If it is on the face or eyelids, where we can't really use the steroids that heavily, we can use topical tacrolimus, retinoids, and things like that to kind of just desquamate the skin. Then if it is moderate, then we can use ultraviolet treatment or phototherapy, which is quite effective. And then if it is very severe, then we need to use the big guns. We need to use the biologic agents, the immune modulators, the interleukin antibodies and TNF inhibitors, and the JAK inhibitors. So these are basically the big categories of biologic agents. And then there are, of course, all kinds of fancy mAb drugs that have come out in the market. Patients may hear about them on the commercials, direct-to-consumer ads, and they may bring those to your attention, and you can just explain to them that based upon their condition and the severity of their condition, they may or may not qualify for those treatments. So next is lichen planus. So lichen planus is a chronic inflammatory skin condition which affects the skin and the mucous surfaces. So this is basically a condition again where we see plaques, and these are going to be different from psoriasis. Why? Because there are 5 P's that we need to remember. So we'll go right into that. So the 5 P's are, these are going to be purple, these are going to be plaques, and these are going to, although there may be a few papules, these are going to be pruritic, so very itchy, and these are going to be polygonal. So there are a few things that are similar to psoriasis in this condition. For example, psoriasis also is very itchy or pruritic. Psoriasis also has plaques, but psoriasis doesn't have purple hue, and psoriasis isn't polygonal. So those are the things that differentiate lichen planus from psoriasis. Now, what are some of the things that can trigger the development of lichen planus? When there are medications that can cause it. For example, ACE inhibitors, methyl-dopa, and then these lesions are going to be present in all kinds of different parts of the body. So they may be in the nails, mouth, and genital areas as well. So this slide is just showing different images with lichen planus. So you can see that the skin lesions are present almost in all different parts of the body. And then there is Wickham striations, which is basically just small scaly striations or linear demarcations on the lichen planus rash. And then it can also be present on the tongue. So just keep that in mind. It can be present in genital areas, where we call it lichen sclerosis. It can also, and it also follows lines of Blasco. So I don't know much more about that. Lines of Blasco are basically just lines on the skin that are imaginary lines, and somebody drew them up at one point and said these are lines of Blasco, and lichen planus is one condition that follows lines of Blasco. There are some other conditions that follow lines of Blasco too. I really don't know very much more about it, and I think it doesn't really make a difference. So similar to psoriasis, lichen planus treatment is going to involve topical and systemic steroids. In the case of mild lichen planus, you can use ultraviolet treatment or phototherapy, and finally you can use biologic treatment. So based upon the severity of the disease, you can do all kinds of different combinations. Pityriasis rosea is basically a Herald patch plaque which is present on the skin, and then there are small additional lesions, and it's a Christmas tree pattern. So the whole point of this is just to remember to recognize it. There's nothing more to do. It's a very self-limiting condition. So moving along, the next thing is vesicles. So what is a vesicle? These are less than 5 millimeter, very small, fluid-filled, circumscribed skin papules, and these are lesions that show on the skin or the mucous membranes. So vesicles have multiple differential diagnoses, and we can go into detail in all of them, but they are very simple and straightforward. So they can result from herpes infection. In that case, we can say it's either herpes simplex or herpes zoster. If it's herpes simplex, it can be herpes simplex type 1 or type 2, depending upon what virus is involved, which can cause oral mucosa involvement or genital mucosa involvement. Herpes virus can also cause herpetic whitlow, that is one differential diagnosis, and then herpes zoster can cause chickenpox or shingles. So those are the things that we need to look at in more detail in the next few slides. So this one is about herpes zoster, or Varicella zoster, which is basically shingles, the other name for it, where you have vesicular lesions in a dermatome distribution, and these are extremely painful. You may not see itching, but pain is going to be there, and if it's there, then obviously we need to make a quick diagnosis so we can treat the patient. The hallmark feature of this particular disease is that the patient is going to have it in a dermatome distribution. Chickenpox is basically herpes zoster infection, and it is a maculopapular vesicular rash where patients have groups of vesicles and papules and macules in different parts of the body showing up in crops. So they are going to be in different stages, and they will evolve from one stage to the next over time, and you can see different types of lesions at the same time all over the skin. So you will see groups of all kinds of different lesions, and these are going to be extremely itchy. They are going to be contagious. Patients are typically going to be otherwise healthy, so they're not going to be that sick. They may have low-grade temperature. Typically these are self-limiting, so they just get better on their own. And this is herpes labialis or herpes simplex virus infection, which causes cold sores. Herpes simplex virus type 1 can cause cold sores, type 2 can cause genital herpes. It used to be that way, but now lately we have realized that actually type 1 and type 2 overlap quite a bit. So type 1 can cause genital and oral, and type 2 can cause genital or oral. So there is no demarcation, there is not much differentiation, there is quite a bit of overlap. And treatment is the same, which is acyclovir or valacyclovir. Herpetic vitiligo is basically a painful condition caused by herpes virus and usually occurs on fingers around the skin, on the skin, and patients have a lot of pain. So they may show this, and you may misdiagnose it as dermatitis. But when you see that there is pain as opposed to itching, then you should go ahead and make the diagnosis of herpetic vitiligo, and of course we need to treat it with acyclovir.